All right, well, let's get started. I am so pleased to be able to announce Dr. Ashfaq Marghoob, who's going to be speaking to us today. Dr. Marghoob is unique in which he has trained in double boarded in both family medicine and dermatology. So I think that not only can he communicate with me, but I think he understands your needs and wants, and be able to see kind of dermatology from a family medicine standpoint is a pretty cool thing. He has numerous awards and honors, but I think probably the thing that sets Ash kind of apart from anyone else is he has done more for the usage and understanding and education of dermoscopy than anyone else, probably worldwide. And he might argue against that, but I think that's true. When I was just brand new out of residency, my wife and I went to his American dermoscopy meeting, which was in Glacier back that year. And I had learned a lot about dermoscopy and how to use a dermatoscope when I was in training. But he really expanded my understanding and my use of my dermatoscope, which I use every single day on every single patient, and it helps me determine what to biopsy and what not to. And it really is I don't carry a stethoscope. I have one somewhere, but my dermatoscope I use every single day, and it helps save and change people's lives. So I really look forward to hearing from Dr. Marghoob and have him share these pearls from dermoscopy.
All right, thank you for the invite. It's a pleasure to be here. And we're going to do like warp speed through this presentation. Even a 5-day course can't cover everything in dermoscopy. So I'm going to give you a flavor and hopefully create enough curiosity that you want to kind of take it to the next level. So my disclosures, but hopefully you'll see that they don't impact anything that I'm saying. And so what I'm going to concentrate on is sort of a revised 2-step algorithm of how to evaluate a lesion that you're not quite sure what it is, what the diagnosis is. And the first step of that algorithm really goes through the benign lesions. So it's a way to maybe reassure yourself that, yes, this is a benign, or to differentiate it from melanoma and be more reassured that it's okay to monitor such a lesion. And the first one of those in the tier is the nevi. So, and that includes the so-called dysplastic nevi, atypical nevi. I thought, by the way, that last lecture was absolutely spot on and fantastic. So in dermoscopy, what we start to realize is that all of these nevi, they tend to have similar patterns, whether you call it mild, moderate, severe, junctional nevus. They all share certain morphologic features on dermoscopy. And so we don't really use that terminology anymore when it comes to the world of dermoscopy. We just talk about the patterns that we see. And there are a group of organized patterns that have been described for nevi. Those are the ones that I will kind of highlight. But I'm going to also share with you there are a couple of caveats for each one of these that requires you to think a little bit deeper. So on the very cursory look, we know that these are all benign patterns, but they always have to be in the right context. And that's sort of what I'm going to highlight here. And basically what I'm discussing is what's known as the black swan event, where you know that this is a benign pattern, you've been taught this is a benign pattern, whether it's on the clinical eye, on the dermoscopy eye, and then to your horror, you find out that it's not. It actually ends up being a cancer, all right? So that's a black swan event. These exceptions don't break the rule, right? They actually prove the rule. But what they tell us a little bit more is that there are certain scenarios where you need to be aware of such a black swan event. And in the world of nevi, those caveats are dependent on skin phenotype, on the moles that you have on your skin, on the amount of sun damage you have, on your age. And we will go through some of those as we go through these nevi. So the first group of benign pattern nevi are the so-called reticular nevi. So this is a reticular pattern, grid-like pattern that can be diffused throughout the entire lesion or patchy within the lesion, but the patchy distribution tends to be quite organized, and the skip areas are also kind of symmetrically placed within the lesion. So this is the classic reticular pattern that is diffused throughout the entire lesion, and this is the patchy pattern of network throughout the entire lesion. In both scenarios, the network itself is light brown and very homogeneous in its appearance in terms of its thickness and its color throughout. And the holes of the network also are very uniform in their appearance. So what's the black swan event here? The black swan event here has to do with age and sun-damaged skin. So those are two factors that are going to play a role. And I'm going to give you sort of a very blatant example of that. So here is a pigmented lesion on the chest of this older gentleman, sun-damaged skin or chronically sun-exposed area of the skin. Obviously, you clinically already know that this is something weird, right? I mean, this has irregular borders, it's large, and it's not been there since birth, so it's an acquired lesion. So on the clinical level, you already should be suspicious of the diagnosis of melanoma. And when you look at it dermoscopically, it doesn't scream out at you as being ugly. It has a network pattern that's relatively regular, although the patchy distribution may be a little bit heterogeneous, but the distribution of the network is relatively regular. And this is one of those exceptions that when you see an acquired pigmented lesion in an older individual that is larger than 6 millimeters, you have to be thinking along the lines of a malignancy, despite what dermoscopy shows. And I'll give you another example of a similar scenario. So you have a patient here, sun-damaged skin, an isolated, large, lentiginous lesion, acquired, sun-damaged skin. Irrespective of what you see on dermoscopy, you should be thinking about the possibility of melanoma. Fortunately, these are the so-called melanomas on sun-damaged skin. They tend to be very slow growing, and in fact, some now consider these to be the drivers of the overdiagnosis of melanoma. So melanomas that are there, yes, but melanomas that are not going to lead to the death of these individuals, right? So they occur in an older population, sun-damaged skin, and are very, very slow growing. The second set of nevi are the so-called peripheral network pattern with central hypopigmentation or central hyperpigmentation. That central hyperpigmentation is known as a central blotch. And so here is the peripheral network pattern with central hypopigmentation, and this one with the central hyperpigmentation. So what's the caveat or the important things that you need to know about these two patterns? They are predominantly driven by your underlying phenotype. So do you have fair skin or do you have darker skin? So skin color, skin phenotype is the main feature that you need to pay attention to. In fair skin, so type 1, 2, and up to type 3 skin, you can see nevi that have a peripheral network pattern with central hypopigmentation, and you can also see nevi that are completely homogeneous tan to pink in color, and we'll talk about these separately a little bit later. And as your skin gets darker, so past skin type 3, then you start to have these nevi with network and a central blotch. Okay, and that blotch can be so prominent that it can encompass almost the entire lesion. You can still see a little bit of the network at the periphery, and again, that pattern will still adhere. So peripheral network, central hyperpigmentation. So what is the black swan event here? I think it should be pretty clear that when you see the wrong pattern nevus in the wrong phenotype, right? So in a very fair-skinned individual, if I saw a very dark lesion, it becomes an ugly duckling by definition, but dermoscopically, it's also an ugly duckling by its pattern. It shouldn't be there. And vice versa, if you have somebody that has dark skin and you're seeing a faint nevus or peripheral network with central hypopigmentation. And there are a couple of papers that highlight these patterns, and this is just one that one publication from the Archives of Dermatology that shows that an individual that has many of these so-called reticular nevi in type 3 skin, this is her normal background, a signature nevus pattern, and then she has one that had the central blotch. It's the outlier. It's also a pattern that shouldn't be there, right? It should be in darker skin, not in this skin phenotype. The next one are the globular patterns, and there are three types. So you have peripheral network with central globules. You have round to oval globules throughout the lesion. And then you have one where the globules are very large and almost create like a cobblestone-like appearance to them. So here is the peripheral network pattern with central globules, a benign pattern. Then you have the globular pattern made out of round to oval globules throughout the entire lesion. And then you have ones where the globules are a little bit larger, creating this cobblestone-like pattern. So what's the caveats here that you need to be aware of? It's going to be anatomical location. And this is actually another thing that dermoscopy has done. It has opened up our window into sort of looking at embryology and how things form. And one of the things that we have learned and taught by our embryologists is that melanocytes move to the skin in two different pathways during embryogenesis. One is a dorsolateral route and one is a ventral route. The dorsolateral route tends to go predominantly to the extremities, and the ventral route goes predominantly to the torso. The ventral route goes along nerve fibers and tends to be deeper, and the ones dorsolateral tends to be more superficial reticular, deeper globular. Therefore, your reticular nevi are predominantly on your extremities, some on the torso as well, but your globular nevi are by and large located on your head and neck and torso. They're almost non-existent on the extremities because of this, of the migration pathways and of how nevi get to the skin. And so you have on your central portion of the body, so your torso, head and neck, is where you see the globular pattern. So by definition, if you see the globular pattern in an acquired lesion on the extremity, you got to watch out. And I'll give you an example of that. This is a patient who had an invasive squamous cell carcinoma that was removed, and she has a new pigmented lesion close to the scar. And you can see that this is a melanocytic neoplasm and has small round globules, right? Not very concerning by itself. The only concerning feature is its location and the fact that it's an acquired lesion in this individual. And I want you to just compare and contrast that to a nevus in a young individual on the back, where most of the nevi in young individuals will have a globular morphology, and look how similarly they look, right? Almost identical, in fact. And really, it's only the knowledge of knowing that this is just not in the right place at the right time in evolution for it to be there. So again, keeping that perspective in mind, these are lesions that, despite revealing sort of a mild globular pattern, are still would still be concerning. Then we have a group of lesions that are your peripheral globular pattern nevi, and then the second one that we'll discuss is your sort of starburst pattern nevi. So in the peripheral globular nevi, they come in different flavors, but the anchor to them all is the fact that they have globules around the entire perimeter of the lesion. And these are what we have now learned are nevi, and if you were to look at it histologically, they would be moderate dysplastic nevi, but again, it's a benign lesion. But we know that this group of lesions begins their life, at least 50% of the time, with this pattern. And if you were to follow this lesion over the course of time, this is what would happen. At 6 months, it would become symmetrically larger. The peripheral globules would become a little bit smaller. At 14 months, they become smaller yet, a little bit sparser in their distribution. Continue to follow it over. Now at 36 months, those peripheral globules are fading away. The lesion has a reticular pattern. At 50 months, you don't see those peripheral globules anymore. You just see network. And that point, this lesion is in senescence, and it doesn't matter how much longer you follow it. This is now the lesion 10 years later. right? And you can see that it has not changed. So the peripheral globules, what they indicate is that you're catching a nevus in its developmental stage. So it has not yet entered senescence. And so these are lesions that we now deem to be benign, and we actually don't monitor them because we know they're going to change. And from the inception to the point of senescence takes about 5 years. So what is the caveat that's important here? There are actually two. So one is going to be patient age, and the other one is going to be location. And remember the globular pattern mainly on the torso, head, and neck, right? And it holds true for this group of lesions as well. So in terms of age, new nevi, they tend to develop in youth, all right? Up to about age of 40. You can develop new nevi after age 40, becomes pretty uncommon. So new peripheral globular lesions in somebody in their 50s, 60s, 70s becomes concerning just by the fact that you shouldn't be having a new growing lesion at that age, right? And then the other one is anatomical location. So the age issue was brought out already now in about 3 or 4 different studies. This was the first one that showed that if you have this peripheral globular pattern, it tends to occur in youth and not in old age. And in fact, if after the age of 50, if you see a pigmented lesion with peripheral globules, you have about a 50% chance that that lesion will end up being a melanoma. So at that point, we don't take chances. It says at that age, we just go ahead and biopsy these lesions. But if you are, 30, 20, and you're having a peripheral globular nevus, that's your normal pattern, especially for somebody that has the trait known as the atypical mole syndrome. That's what they will form. And this is another paper that kind of highlighted the same, that these are lesions that occur more commonly in younger individuals. But then the second part that we also learned, and there are now 3 publications that have confirmed this, is that this peripheral globular pattern tends to occur on the torso for nevi. When you see a peripheral globular pattern on the extremity, think melanoma irrespective of age, okay? So, and it has to do, again, with migration patterns of melanocytes to the skin. You just don't get the globular pattern on the distal extremities in terms of nevus evolution. So location and age are going to play the major role. Then we have the so-called starburst pattern nevus. And this is a very unique pattern that occurs in a subset of Spitz nevi known as Reed's nevi. Okay, and this is what they look like, and it's like this really unique pattern. You'll recognize it the minute you put your scope on. You'll say, "Oh, this is a starburst pattern," and it is highly, highly, highly suggestive of a benign Spitz nevus, as I said, of a Reed's nevus. Similar to the peripheral globular pattern, what this pattern indicates, it's that it's a Reed's nevus that you're catching in its evolution stage, right? Those streaks that create that starburst pattern are actually the expansion of the nevus, so before it has entered senescence. So if you now were to follow a lesion that has a starburst pattern, you will see the same thing. There's symmetric growth of the lesion, and then eventually those streaks that are at the periphery will disappear, and when this Reed's nevus enters senescence, it'll have a homogeneous pattern with a central bluish hue. That is the senescent stage of the so-called Reed's nevus. These nevi can then undergo involution later in life, but at least for now, they have reached a state of senescence. So it's a benign lesion. So what is the caveat here? And the caveat here is only age. That's it, okay? And this is a really important one to keep in mind. Under the age of 12, and we are now fairly confident that we should push that age up to 16, and the new guidelines will probably do that, that under the age of 12 to 16, a peripheral streak pattern, the starburst pattern, is benign. You can dismiss it. You can send the patient home. The only thing that enters the differential diagnosis for such a lesion is superficial spreading melanoma. And superficial spreading melanoma under the age of 12 to 16 just doesn't occur, okay? And so if under the age of, I'll say the guidelines, current guidelines are 12, but as I said, it's going to probably go up to 16, it's benign. The older you get after that, the higher the pretest probability that that same exact pattern will be a melanoma, superficial spreading type. And in fact, after the age of 50, 50% of lesions with a starburst pattern will prove to be melanoma, okay? So we do not monitor lesions with a starburst pattern in older individuals. End of story. In individuals that are kids, we totally dismiss it, right? And these are the guidelines that I was referring to. Right now it says under the age of 12 that you can just forget about it. If it's older than that, we do recommend that these be biopsied. And I just give you two examples of a starburst pattern, but I can tell you that if you took the top one and put it on the individual at the bottom who is 5 years old, it's benign. It's a benign pattern. These, you don't get superficial spreading melanoma with a starburst pattern in kids. It just doesn't occur. And if I saw the bottom pattern in the individual on the top, it would still require a biopsy. But remember, 50% of the time, it'll still be a Reed's nevus. It's not that it is a melanoma, but a 50% chance that it will be a melanoma. So age is the only discriminator for this pattern. And then the last patterns that we have are the homogeneous. And there are three types of homogeneous patterns. You have the homogeneous brown, homogeneous blue, and homogeneous tan to pink. So three patterns. So here they are, so what they look like. Now let's talk about what are the caveats we need to know. So homogeneous brown occurs in small congenital nevi. Okay, that's where you see them. So your patient history, lesion history is going to be critical here. So if I have a homogeneous brown lesion, and the patient is saying this is, like say a 50-year-old person is saying this lesion is new, all bets are off, right? So this should be there forever, since birth, right? So since birth, that's a very common pattern that we see in small congenital nevi. So patient history is going to be crucial to help you to know when is homogeneous brown acceptable and when not. How about homogeneous blue? Well, homogeneous blue is seen in blue nevi, all right? There's one exception and only one, and that exception is epidermotropic metastasis of melanoma. So a patient who has had a melanoma, a history of melanoma, that develops metastasis to the skin can have skin lesions that look homogeneous blue. And so history is going to be important. If a patient has a previous history of melanoma and you're seeing a lesion that's homogeneous blue, you have to at least be thinking of the possibility of a metastasis. Nodular melanoma does not appear like this. It has a different pattern. We'll talk about that later. So that's the only caveat. So in a patient who doesn't have a history of melanoma, homogeneous blue is a blue nevus, okay? Now, what about homogeneous pink? And here comes a little bit of I don't want to say a dilemma, but we could, for lack of a better word, say it's a dilemma. Okay, what's the dilemma? You will see in my second talk that one of the anchors to the diagnosis of cancer is to look for neoangiogenic vessels. So looking for blood vessels in a lesion can help you to know when something is benign or malignant. Okay, where are blood vessels located? They're located in the papillary dermis and dermis. Okay, what allows light to penetrate through to get to that dermis level? It's going to be that you don't have eumelanin that absorbs light. So the less pigment you have, the more light will enter the papillary dermis and the dermis, and the more likely you are to see the normal vessels that you see that we all have, right? And very different than if you have darker skin and you're seeing vessels in a lesion that speaks in favor of neoangiogenesis. So in fair-skinned individuals who have these light nevi, in all of them, you will see vessels, all right? And these vessels will look a little weird. They'll look similar to the vessels that are described for amelanotic melanoma, So, how do we actually figure this all out? Well, here is what's known as the comparative approach. You need to be able to look at what are the other lesions, the nevi, in this person with type 1 or 2 skin have. And so the comparative approach becomes the key here. Obviously, skin color by definition, it's if this was occurring in type 4 skin, you'd be or 5 skin, you'd be concerned. So these are lesions that we're only talking about type 1 and 2 skin. And so here you go. You see a lesion and you see vessels, and you'll see later that vessels in a pink lesion, you should be thinking melanoma, which means that in every single nevus that you see in an individual with type 1 and 2 skin, you'd be thinking melanoma. So how do we differentiate the two? And here you start looking at the other nevi that this patient has. If the patient has no other nevi, you're kind of committed to a biopsy on this lesion. But most of the time, these individuals have other nevi. So look at all the other nevi. And they all have the same pattern. And so here you can sort of rest assured that based on the signature pattern, the signature nevus pattern of this individual, you can continue to monitor these individuals, okay? So, on the very cursory, superficial look of it all, there are a group of benign patterns that 99% of the time are benign. And I just showed you the caveats for each one of the patterns has its own unique black swan event that you just need to be aware of, right? And when to say that even though it looks benign, maybe I should still be concerned about the lesion, right? That was sort of the take-home message of that. Now, what about intradermal nevi? So intradermal nevi on the second tier, there's a group intradermal nevi, and then we also have the so-called dermatofibroma there. But let's talk about intradermal nevi. There are two types. We have intradermal nevi that are known as Unna's nevi. These are the fleshy ones. They tend to be sessile and pedunculated. They have a mammulated surface. They tend to occur on the torso. And then you have the Meischer's type. Those are the dome-shaped ones that occur predominantly on the face, right, of individuals. So two morphologic types, and the Meischer's type also have sort of a smooth surface clinically. Dermoscopically, what do Unna's nevi show? They have globules. They can have milia and comedo openings present within the lesion. They can have a little bit of brown pigmentation, and they can have some hypopigmentation as well. That's pretty much the dermoscopic features that you see in these so-called Unna's nevi. In terms of the vessels that you see on Unna's nevi, they have a vessel that's known as a comma vessel. And basically all this is that, you know, you have a mammulated surface. Each one of those mamilla, actually a dermal papilla. The dermal papilla has a vessel that comes up into it and then loops around back, right? So that's your vessel coming into the dermal papilla. And in these nevi, when you put your dermatoscope on, you're kind of pushing it to one side, and this loop vessel now is being seen at an angle, and that's your comma vessel, okay? So in an intradermal nevus of the Unna's type, comma vessels are accepted and the normal vessel pattern. This is the only time in a nevus, other than the type 1 and 2 skin pattern that we just spoke about, that a vessel pattern is considered normal. Comma vessels in an intradermal nevus. Now, how do you apply that? Obviously, you say, okay, so what? How does that help me? So let me show you an example of how that helps. So here are two lesions. They look identical to me, yeah? They're both sessile, they're both mammulated. Now, you could say clinically, maybe the one in the axilla is just not in the right place for an Unna's nevus, but I can show you many Unna's nevi that occur in that location. But anyhow, morphologically, at least for me, they look identical. So what's the harm? You put your scope on it. What do you expect to see? Some globules, some tan pigmentation, some hypopigmented areas, maybe some comma vessels, right? Easy. A millisecond for you to know whether it's a nevus or not. And then you take a look at the two. The one on the right is a classic intradermal nevus, a mammulated surface, comma vessels. It has some comedo-like openings. The one on the left, not at all. It has none of the features of an intradermal nevus. And in fact, if you look at the vessels at the perimeter, There's not a single comma vessel. They're all weird polymorphous vessels. It doesn't fit. And when it doesn't fit, you biopsy. The one on the left happens to be a melanoma. The one on the right is a nevus. That's how dermoscopy helps, right? So it takes your clinical morphology to another level to improve your diagnosis. And then you have your dome-shaped Meischer's nevi. And here again, globules, brown pigmentation, hypopigmentation are common. And here comes in one of the issues that arises when it comes to vessel pattern. It turns out that in your Meischer's nevi, you can have the so-called arborizing vessel. An arborizing vessel is associated with basal cell carcinoma. We'll talk about that in the second half. And so some intradermal nevi can be confused for basal cell carcinomas. But this is not a new problem. In the 1800s, people were debating how do you tell the difference between an intradermal nevus of the Meischer's type on the face versus a basal cell carcinoma. At that time in the 1800s, one of the clues that they determined was an anchor to the diagnosis of an intradermal nevus was the presence of hair. Hence, born the myth that if you have hair in a nevus, it means it's benign. It's a myth. It was only directed towards differentiating intradermal nevus of the Meischer's type versus a basal cell carcinoma, right? And that's it. That's the only place. So if you have hair in it, it's not a basal cell. The other thing is if you dissect the arborizing vessel a little bit more in detail, what you will realize is that in intradermal nevus, the arborizing occurs only at one point, creating the figure Y. So you have a vessel going up, splits into two. That's it. Whereas in a basal cell, it splits, and then splits, and splits, and splits, right? So multiple arborizing points is a basal cell. But with that said, do I end up biopsying some intradermal nevi that I think are basal cell and it comes back as an intradermal nevus? You bet. Yeah, sometimes it's impossible to tell them apart. So that's your Unna's and Meischer's nevi. And then a little bit about the hair issue. The skin marking, sort of also an interesting part, and again, it goes back to the 1800s, and this was also the observation made by dermatologists back then, that if your skin markings were preserved, it speaks in favor of a nevus. If your skin markings are gone, it speaks in favor of a basal cell. Hence, it also explains why basal cells are shiny. So if you remove skin markings, they become shiny, right? So skin markings is another sort of clue, but just to be aware of, and bring some historical perspective. What about dermatofibromas? Dermatofibromas on one side are super easy to diagnose clinically, and sometimes on dermoscopy can be a little bit confusing. The reason that they're confusing on dermoscopy has to do with the pathology that has pigment in the reedy ridges, it has fibrosis, it has vasculature. So the combination of features are also features that are seen in cancer. And so the anchor to the diagnosis for me when it comes to dermatofibroma is that it has the features of a dermatofibroma as shown on this slide, meaning it has a peripheral delicate network, it has central white scar-like area that can have shiny white lines on polarized light. Towards the center, it has ring-like globules, and it has some vessels also towards the center. That pattern is acceptable for dermatofibroma as long as one other feature is also present. And what is that feature? That it dimples, okay? So the pattern has to be consistent with your clinical exam and the fact that it's dimpling. In individuals that have very fair skin, if you have a dermatofibroma, it will lack the network because you don't have eumelanin, right? So you won't see the pigmented network. So all you'll see is the vessels and the collagen stroma, which is the shiny white structures. And in those lesions, if they don't dimple, you end up biopsying them to rule out amelanotic melanoma, okay? So here's your classic dermatofibroma, occurs 70% of the time, peripheral network central scar-like area. That's all you see. If you look at a dermatofibroma in different light sources, so if you have your dermatoscope and you look at it with non-polarized light and polarized light, you will see different structures. Under polarized light, you will see the shiny white structures or lines, which are in the middle picture on this collage. If you take your scope off the lesion, you will see the entire vascular blush, so the vasculature that's part of the pathology of a dermatofibroma, so they'll appear really, really pink. So again, they can have overlapping features with malignancy, but the anchor is that all of the features are still consistent with the diagnosis of dermatofibroma as long as it also dimples when you do the Fitzpatrick's test. Another example of two dermatofibromas showing you the shiny white structures that you see with polarized light. Again, we're going to talk more about the shiny white structures in the second half of the talk. And in both cases, you have dimpling, knowing that these are dermatofibromas. These are the so-called ring-like globules. You can see that they're sort of brown, donut-like structures, more towards the central aspect of the dermatofibroma. And then in dermatofibromas, you will also see vessels. So you can see that it's a little bit of a difficult lesion if you don't put the whole clinical and dermoscopic together. The take-home message is that a dermatofibroma, number one, should dimple, and number two, should only have these structures and nothing more, right? If you add anything else to this, you add a globule, right, or some blue color or anything else, then even if it dimples, you got to be thinking along the lines of cancer, okay? So only these structures, only in this pattern, and only if it dimples is it a dermatofibroma. Okay, what about seborrheic keratosis? So seborrheic keratosis has a constellation of findings on dermoscopy as well. Remember, clinically, they are well-demarcated lesions, have a keratotic surface, and then on dermoscopy, what they reveal are milia cyst, comedal-like openings, the invaginations known as your sulci and the raised portion gyri, so gyri and sulci. In irritated seborrheic keratosis, you can have a hairpin vessel known as a looped vessel with a whitish halo, and very early seborrheic keratosis or a solar lentigo on its evolutionary path towards a seborrheic keratosis will have moth-eaten borders as well. So milia cyst, I think easy, right? White to yellowish structures that you see in seborrheic keratosis. In very robust appearing seborrheic keratosis, you can see it even with your clinical eye. Comedal-like openings is when this milia cyst travels up the epidermis and opens up to the surface of the skin. They become a comedal-like openings. That keratin oxidizes and becomes brown in color, and so that's what you see the comedal-like openings with. So here are your milia cyst. Here are your comedal-like openings, and histologically, when you look at it, you'll see the inclusion cysts, which are your milia, and when they open up to the surface, you have your comedal-like openings that usually appear brown because the keratin oxidizes and becomes brown in color. So, if you have a keratotic lesion with many, meaning 3 or more, milia cysts and comedal-like openings, it speaks for the diagnosis of a seborrheic keratosis. An important thing to be aware that milia cyst is a structure that is seen more conspicuously with non-polarized light and almost disappears with polarized light. Now, why is that important to know? Because most of the scopes that are sold today are dual, so they have the ability to toggle between polarized and non-polarized. By default, when you turn on your scope, the default light is polarized. And there's a reason for that, because it has the highest sensitivity for finding malignancy. So that's why it's defaulted to polarized. But in the polarized mode, you don't see milia, for example. And therefore, some seborrheic keratoses will appear concerning because you're not seeing the diagnostic structure. it will require you to toggle to the non-polarized mode for you to see that. And that is highlighted in this image. So what you're seeing here is a seborrheic keratosis in the polarized mode. And I think the AV tech may need to just hit that slide. And then it'll toggle between polarized and non-polarized. Can you just hit the slide? And yep, okay. There the milia. So non-polarized, non-polarized, non-polarized. So you're just basically toggling the light source from the polarized to non-polarized mode, right? And so if you only use polarized dermoscopy, you will probably over-biopsy seborrheic keratosis, okay? All right, gyri and sulci are your sort of in your seborrheic keratoses that have the raised portions. They create this pattern that when they become very robust can start to take on the appearance, what's known as a cerebriform pattern. Some people call it a coral reef-like pattern. But this is your classic sort of cerebriform pattern caused by the gyri and sulci of a seborrheic keratosis. Why are those darker areas? Those are your keratin-filled invaginations, and the keratin that becomes oxidized is brown in color, hence giving you the darker appearance. And yet another seborrheic keratosis with the so-called cerebriform pattern. Now, take this lesion into an earlier stage, okay? So before they become really robust, you know, gyri and sulci that you can see with your naked eye. Well, at that point, these lesions have what's known as a fingerprint-like pattern, and these are the very early sort of gyri that are forming. And this is what they look like. It's not quite a network. These are sort of lines that don't interconnect to create a grid-like pattern as I showed you in the nevi. And this is sort of the earliest pattern that you see in a solar lentigo on its evolution towards a seborrheic keratosis. And yet another example of that same kind of a pattern of this early solar lentigo on its evolution towards a seborrheic keratosis. Now, one of the sort of maybe drawbacks to dermoscopy is that you have taken a three-dimensional object and you've converted it into 2 dimensions the minute you stick your scope on the skin, right? And it's important to appreciate that the third dimension that you're seeing with your clinical eye is also important and needs to be factored in. And I give you an example of that. So here are 2 lesions. You stick your scope on. It's like, I have no idea what's going on here. I got nothing to anchor my diagnosis on. And so by default, I got to be thinking about cancer, right? But I can tell you that on the clinical eye, on side lighting, I already know what this is. But I can bring that third dimension out for you. And if you are also teaching residents, this is sort of a neat one to sort of show residents the same. So what do? You take your surgical marking pen, you mark up the lesion, and you wipe off the ink. Now, where's that? Well, most of the time it's gentian violet, right, in the surgical marking pens, but anyhow, where does the ink adhere to? The keratin. So if there are any comedor-like openings, they'll adhere to the ink, will be blue. Any sulci that have keratin will appear blue as well. So mark these up, and what do you see? You now see the gyri and sulci, you see the comedor-like openings, right? To know that these are seborrheic keratosis. You would see these with your naked eye as well, okay, on side lighting. But it's just to show you that if you only rely on dermoscopy images without looking at the clinical, right, it can lead you to more biopsies than is needed. Where else can this ink test help? Well, anything that has a place where ink can kind of adhere to. For example, porokeratosis, right? Classic, another example where you have a red lesion, you're not quite sure, is this an early squamous cell carcinoma, or is this a porokeratosis? You ink it up, you see that just the rim is highlighted with the ink. That's your classic porokeratosis, benign lesion, you can leave it alone. And then we have hairpin vessels with a whitish halo, and these are seen in irritated seborrheic keratosis, and so here is one such lesion. And I will zoom in on that, and you can see these little looped vessels, and they're all surrounded with a white halo. And there's a beautiful study that came out last year that looked at the difference between irritated seborrheic keratosis and squamous cell carcinoma, and what was the key difference? It was the white halo. If you have a white halo around the vessel, it's an irritated seborrheic keratosis. If they are pink, there's no white halo around, it speaks in favor of a squamous cell carcinoma. And then I said moth-eaten borders, so the earliest forms of a solar lentigo and its evolution towards this seborrheic keratosis. Here's your sort of classic moth-eaten border. It also has the fingerprinting of your solar lentigo, yet another solar lentigo, moth-eaten borders, fingerprinting, and nothing else. Now, obviously, this is a really common tumor. We see it all the time, hundreds, if not thousands a week. And some of them will break the rules. And so you will at times end up biopsying a lesion that you think is cancer that ends up being a seborrheic keratosis. That's kind of a normal thing. And so I give you an example of such a lesion. So here is a lesion that, yes, it was keratotic, but it had features that were a little bit confusing. It had some comedo-like openings. It had a couple of milia cysts. It had a couple of, gyri. But then it had some irregular colors. It had some irregular globular structures. It looked a little bit chaotic. And so, you will see when we talk about melanoma that these are sort of overlapping features with melanoma as well. And so this is a lesion that ended up getting biopsied, but it ended up being a seborrheic keratosis. It's okay. So that was the seborrheic keratosis, and it's a reminder that no matter how good you get, no matter how many technologies you put at it, no matter what other test you apply, you will always have some benign to malignant ratio. You will never be 100% correct. And I just highlight two lesions, one that was biopsied was seborrheic keratosis, one that was biopsied that was a benign nevus, but on dermoscopy, impossible to tell apart, and you're basically committed to a biopsy. Another example of something that dermoscopy can help you with is that it will help you to know when things are just not right. And while, yes, you will end up biopsying some benign lesions that you think are cancer, but on the flip side, it will also help you to find cancers that you otherwise wouldn't. Okay. And this is just one example of a lesion that looked more like a seborrheic keratosis, and on the right-hand side, there are some milia, there are some comedoid-like openings, but if you look at the left-hand side, there's an amelanotic component that has a lot of vessels, and they're not looped vessels with a white halo. This is not a part of a normal seborrheic keratosis, and so this is either a weird seborrheic keratosis, I accept, or it's a cancer mimicking like a seborrheic keratosis, or it's a collision lesion between a cancer and a seborrheic keratosis. And in this case, it was a collision between a seborrheic keratosis and an amelanotic melanoma. So it will help you. I'll give you another example of how it helps. Look at this lesion. Of course, this is a seborrheic keratosis. Don't even put your dermatoscope on it. Well-demarcated borders, keratotic surface, can't be anything but a seborrheic keratosis. But what's the harm? Put the scope on it. When you put your scope on it, there is nothing here for seborrheic keratosis. You have atypical globules. You have milky red colors. You have irregular vessels. You have something called a negative network, which we'll talk about in the second part of this in this talk. So none of the features of a seborrheic keratosis, we do the ink test, and none of the comedo-like openings light up. There are no sulci that light up. This ended up being a 4 millimeter thick verrucous melanoma. It's not a collision tumor between a melanoma and a seborrheic keratosis. It, in fact, is a melanoma, right? So it will help you to find those lesions that are mimicking benign lesions, but obviously it requires you to put your scope on it, okay? So next one is we talk about vascular lesions, and this is really, really easy. Vascular lesions have dilated blood vessels, and if they are very slow, sluggish flowing vessels, they'll be maroon, in color. If they thrombose, they'll be black in color. If they're very fast flowing, they'll be red in color. And if they're lymphatic, they'll be clear spaces. And those are known as lacunae. And again, the reason for the colors of the lacunae now you know. And so they can be anywhere from clear to bright red and black to brown in between. So here's your lacunae definition and some examples. Here's sort of the maroonish lacunae, right? So each is a dilated blood vessel separated from the other with intervening vascular space, collagen space. And here is the pathology. Why I highlight that intervening collagen space, right, is because you have a dilated vessel and then you have another dilated vessel, and obviously there's matrix in between. And so if you don't see that sharp demarcation in between, be careful. So I'm going to highlight that with another case. On the right-hand side is your classic lacunae. So they have dilated vessels, and then they have the stroma around them, sort of separating one from the other. On the left-hand side, you have sort of these reddish structures, but they're not separated one from the other with intervening stroma. When you don't see that intervening stroma, think cancer, okay? And in this case, this was a melanotic melanoma. If it gets thrombosed, then it'll be black in color, and the blackest of black is thrombosed blood, so that'll be what they appear. If you have a combination of these, so you have maroon and red and black, you end up with something called an angiokeratoma, all benign vascular, but they all have the same kind of pattern. So look at this, right? Lacunae, intervening spaces of your matrix, and then you have different colors. The minute you have black in addition to maroon and red, then think of angiokeratoma. Does it make a difference? Not really. It's more for your own ego that you know exactly what it is, but it's benign. And then when you have the clear spaces, this happens to be a lymphangioma, then you'll see just the clear lacunae as shown on the left-hand side. Sometimes you can have a mix between lymphatic and blood, and you'll see that level, the blood level and the lymphatic level kind of layer out within the lesion. And that's highlighted by this lymphangioma and just the pathology of this lymphangioma. Now, there are a couple of other lesions that are worth mentioning. One is a sebaceous hyperplasia. Why is sebaceous hyperplasia worth mentioning? Because when they become big, they start to take on an appearance similar to a nodular basal cell carcinoma. So to know when it's a lesion that's nothing, meaning sebaceous hyperplasia, you do need to know what the features are. So what the anchoring features are you see these yellowish globular structures that are also known as popcorn-like structures, and there are vessels at the periphery that come towards the lesion, towards the center of the lesion, but don't cross the midline, okay? And that's your classic sebaceous hyperplasia as depicted here. There is one other entity that can have a pattern similar to this, and that's molluscum contagiosum, okay? So keep that in your differential when you see this pattern. Other benign lesions. An interesting one to know is clear cell acanthoma. And what a clear cell acanthoma is, a benign lesion and has a very unique pattern where you see vessels that are distributed, so dotted vessels that are distributed in this sort of almost string of pearls-like distribution. It's a lesion that is pink, has a collarette of scale at the periphery, and on dermoscopy has this very unique pattern distribution of vessels. And so this is the clinical collarette of scale, pink lesion, and you see this very classic string of pearls-like distribution, clear cell acanthoma. Now, there is another group of benign lesions. I will highlight them, but I'm going to put the caveat that this really, all of these, we do recommend get biopsied. It is just for you to submit to the pathologist that I think this is what it is, but you need histologic confirmation that that is indeed what it is. And so the first one is a peroma. And a peroma ends up having a vessel pattern that is fairly unique, and it's sort of this multi-looped vessels with rounded endings. let me show you a peroma. This is a peroma on the abdomen, and I will highlight these multi-looped vessels with rounded endings. When you see that vessel in a lesion, you can say, it's probably a peroma. I'm going to biopsy, I'm going to put on my pathology, rule out peroma, right? But still biopsy the lesion. But that's sort of the hallmark pattern. Another one is xanthogranuloma. I mean, juvenile if it's in a kid, but xanthogranuloma. They have what's known as the sunset pattern. So here is a gentleman with this orangey lesion, and you can see this very unique pattern of this rim of orange around the periphery. That is known as your sunset-like pattern of a xanthogranuloma. Again, we do recommend that they get biopsied just to confirm that you're dealing with xanthogranuloma and nothing else. And then the last one is your pyogenic granuloma. I think always requires a biopsy for confirmation. What do you see on those? Obviously, they're red. They tend to be sessile, bleeding lesions. And they have a structure that we see on dermoscopy, which is known as the white rail sign. And this is highlighted here. Those are those white lines that are sort of interconnecting that have been called the white rail sign. So that was basically step one, right? So let me now kind of give you a preview into what we're going to talk about in the second half. So the second half is going to talk about when none of these criteria have been met, what do you do next? And in that next step, you're really looking for cancer. And it turns out that most cancers are disorganized in their dermoscopic appearance, and then there's a very small subset of cancers that'll appear organized. So in this second step, we separate the lesions into those that are disorganized and those that are organized, and we'll talk more about those later. But I want to give you a sort of a heads up that what do I mean about organized and disorganized? It's not the same as symmetry and asymmetry, okay? It has to do with a very different process of thinking, but we all do it, and I will show you what I mean by that. So I want you to take a look at the next slide and pay attention, because it's only be up for a millisecond, and I'll ask you if it's organized or disorganized. Organized. But you already know it's not symmetric. Pencils on one side, it's not symmetric. But your brain instantly knows that everything is where it's supposed to be, yeah? All right, so that's sort of that concept of organized, not necessarily symmetric. Now, let's take a look at another one, okay? Here we go. Disorganized lesions are almost always asymmetric. Organized, not always, all right? This concept is such a powerful concept that our brain has that in every study that has looked at, concordance in what we are seeing. Do you see a globule? Yes, no. Do you see a streak? Yes, no. Do you see this? Among experts, we are really bad at agreeing upon any given structure, but we are really good at agreeing when something is organized and disorganized. So the most subjective of features is the one we most agree on, and the most objective of features are the ones that we have poor agreement on. Just tells you the power of the brain, yeah? So that's sort of a little bit about symmetry and asymmetry. And now if we jump to the clinical side, right, this is what was started already 50 years ago. We were already starting to figure out, what makes a nevus differ from a melanoma? Well, the ABCDs are nothing more than trying to take that disorganized appearing lesion and put it into some analytical terms, right? But the Gestalt tells you there's something wrong. Now you try to break it into its analytical pieces and you say, well, it has asymmetry and irregular borders and et cetera, et cetera. The E has nothing to do with morphology. The E has to do with biology. It has to do with evolution. That's a separate issue, right? So if a lesion is evolving, especially if it's an older individual, yes, of course you should be concerned. So morphologically, it's only the ABCD, okay? And basically what dermoscopy has done and has pushed the envelope. So now we can evaluate lesions that don't have the ABCDs but still manifest the organized and disorganized pattern. And there, the silhouette of the lesion does not play a role. It is the content of the lesion only that plays a role. And I'll highlight that with these two lesions. On the left-hand side is a nevus. It's the content organized. On the right-hand side is a basal cell carcinoma. Although the silhouette is symmetric and oval, the content is disorganized and therefore should raise concern for cancer. And fortunately, most cancers, whether they're basal cell, squamous cell, melanoma, will have a disorganized pattern, and that's what we'll talk about in the second half of the talk. And with that, I thank you for your attention.
A couple questions. Do you have a digital copy of the two-step algorithm we can send out?
This one?
Yeah.
You can take this one.
The PowerPoint's great.
Convert it to a PDF.
Okay.
Send it.
Okay. Well, for me, that's really helpful. When I first took a course, it was helpful to have kind of a card, and there used to be like a 7-step algorithm. I think this 2-step algorithm is so much easier to use and address. Where is your meeting next year?
So this year's meeting is next month, and that'll be in Monterey. Next year's meeting is in West Virginia.
Okay. Thank you so much.
All right, thank you.
Yeah. So if you're interested, right? So we have another hour of kind of the step 2 stuff, but in a month, the American Dermoscopy meeting is in Monterey, California. It's June 26th to the 28th. They have a virtual option. I have no disclosures with the meeting. It's just fantastic. But we look forward to hearing the rest of Dr. Marghoob's lecture. Next, we'll be hearing from Dr.